Good evening. Welcome to the PI interview on day one of ESOC 2022. I hope you have enjoyed today's program, and now you're holding a nice drink in your hand while watching the ESOC Live TV. My name is Yvonne Chen. I am a stroke physician from Edinburgh in United Kingdom. I'm also the co-chair of the ESOC 2022 PR committee. So today I'm delighted to welcome Professor Simona Sacco from the University of L'Aquila in Italy. She will be the interviewer, and she will be interviewing Professor Bijoy Menon and Dr. Rick Schwartz from University of Calgary, Canada, also PIs of the ACT trial, and Dr. Annette from Haukeland University Hospital, Norway, also the PI of Nortest 2 Part A trial. Both trials evaluated tenecteplase versus alteplase. So now I will hand over to Simona to find out more.
Yes, thank you, Yvonne. It's a pleasure to have the opportunity to interview the PIs of those important trials which were presented today. And I want to start with Annette and addressing the Nortest study. Annette, what was the main reason which led you to run this trial?
We have previously conducted the Nortest study, and that was conducted on the entire stroke population, with basically mild strokes included. And then we actually had some criticism, of course, if this may be transferable to also more severe types of stroke. And then we decided to do the Nortest 2 trial, which was only focusing on moderate and more severe stroke patients.
And what were the main findings of your study?
When we compared the study arms of tenecteplase 0.4 milligrams per kilo, which is a bit higher than the most studies are investigating, compared to the standard dose of alteplase, we actually found that the bleeding risk is increased in the tenecteplase arm. So that's our main finding. So our study was prematurely terminated due to these results, which we had in the safety analysis.
And how can you explain the finding? Is it only the dose, something else? And what will you do in the future?
We're not completely sure why the result is so different compared to the original Nortest study, which was completely neutral. We have some imbalances in this quite small study population of only 200 patients, or 216. Tenecteplase-treated patients were slightly older, or 5 years older. They were more disabled pre-stroke, and they more often were real stroke patients, while the alteplase arm included more mimics. And of course, that may have some impact, but we did not find that in the adjusted analyses. There was still a worse outcome for tenecteplase.
Thank you. Thanks for sharing those insights into the trial. And we have the 2 PIs for the ACT study. And my question for them is, what was the rationale for this study, your main objective?
Thanks, Simona. Our objective was really simple. We wanted to find out if we could actually replace alteplase with tenecteplase in our practice for all patients. We thrombolize acute ischemic stroke patients with alteplase. In all those patients we thrombolize, could we just replace that drug with tenecteplase? Now, the dose we chose was different from the dose that Annette chose in Nortest 2, where we chose a dose of 0.25 milligrams per kilogram body weight. And this was based on our own assessment of all the past literature, as well as the Extend IATNK Part 2 study that actually showed that 0.4 doesn't have any comparative advantage over 0.25 and may in fact have slightly more harm. And so that was the reason why we chose 0.25. And then we did this large study. It's 1,600 patients. In fact, I think after IST3, this might actually be the largest thrombolysis trial that's been done. And our goal actually was to show non-inferiority. And the reasoning was that if we show non-inferiority, and with that sample size of 1,600, if you're showing non-inferiority, it essentially means that the point estimate for tenecteplase would actually be above alteplase. And so if that's the case, then with all the other advantages of tenecteplase, which is a single bolus, it's more cost-effective, it's potentially faster, you would just change practice. And so that was the goal of the trial. It was a large, pragmatic trial to address this question that is real life, which is, would you just replace alteplase with tenecteplase in your practice?
Thank you. Rick, can you summarize the main findings?
Yeah, so what we were able to show is that we demonstrated non-inferiority. So we were able to show that tenecteplase is non-inferior to alteplase. And the point estimate for our primary outcome, which is 90-day modified Rankin of 0 to 1, so a good to excellent outcome, we showed that the tenecteplase arm had 2.1% higher incidence of excellent outcome than alteplase. Now, the confidence intervals do cross 0. It wasn't powered to be a superiority analysis, but we well met our non-inferiority. So the lower bound of the confidence interval was minus 2.6, and that's within our pre-specified threshold of within 5%. And so, as Bija was saying, we demonstrated clear non-inferiority with a trend towards that superiority, but the goal was to just show non-inferiority.
Excellent results.
And I just wanted to make this point too. Like I did see a tweet about, oh, you didn't show superiority. You feel like if we have to show superiority in real life, from the ACT trial, we know that the point estimate for the difference is around 2.1% now, approximately. And so you need to do a 5,000 patient study.
Or higher.
Or higher. So, so it's sort of, like, to me, it's like an oxymoron if, you're sort of, like, because of all the obvious advantages of tenecteplase, you just do a non-inferiority study, show where the point estimates are, and that changes practice.
And I think it's important to know that we didn't see any heterogeneity of effect. So older, younger, men and women, large vessel occlusion, there was not any subgroup in the pre-specified subgroup analyses in which tenecteplase wasn't in the direction of benefit.
And can we change our practice? What do we need?
So Simona, that was the reason why we did the trial. To change practice.
Mm-hmm. It's enough, according to
exactly.
you. Yes.
And so, the goal of the trial was to change practice. And so, like, that's what we ought to do.
That's our hope.
So we have to wait for guidelines.
Yeah, exactly. And we know there's considerable interest amongst the guidelines writers. They were reaching out to us before today, and we were stubbornly telling them nothing. So I'm hopeful that we're going to start to see that reflected in the guidelines soon.
Well, I have a question more for Annette then. I noticed that there was a big difference in mortality between groups in the NOR test to Part A trial, but not so much in the ACT trial. Why is that?
It's difficult to say, but I think probably the quite high proportion of intracerebral hemorrhages may be the answer.
Yeah.
And they use a different dose, right?
Yeah.
So it's the higher dose.
And we have higher bleeding rates, and we have the more severe bleedings as well. So
if you actually look at the ACT trial results and look at the symptomatic ICH rates, so they are very comparable to alteplase, almost similar. And so then, now you use a higher dose, the expectation would be that there would be higher bleeding. And I think this is what played out, right? So, and obviously, like Annette did mention, there are subgroup, like baseline differences. This was an interim done at 200. And, that's, a small sample size. And so that also affects the way.
I'd be curious to hear Annette's thoughts, but, the two trials kind of complement one another to show, at 0.25, we have equivalence to alteplase, and now we also kind of know maybe we don't go to 0.4.
Yes.
And so together we kind of shut the door on that sort of exploration. I don't know if you think do you think we have the answer now?
completely possible.
Yeah.
Yeah.
That's exciting. I think as stroke physician, I've been longing for a simple, easy to administer thrombolytic agent.
Yeah, it
And it
saves,
seems like we've found it.
saves time. You can go home early. So.
Excellent. Well, thank you very much. Any further questions?
No, not from my side.
Excellent. Well, thank you very much. So before we finish the session, I would like to just use this opportunity to promote a few simultaneous publications from today. So that includes the NORTEST 2 Part A trial, which was published in the Lancet Neurology. And from today's plenary, the SET-Point 2 trial, which compared early versus standard tracheostomy in ventilated patients with severe stroke, was also published in JAMA. And don't forget to look out for today's press releases, including summaries of all the presentations in the plenary session today. In addition, there is one public impact press release that was released on the association between gut microbiome and stroke risk. So very interesting. And I would like to take this opportunity also to thank the ESOC 2022 PR committee members, Lin-Xin Lee, who is our co-chair, Halva Oygarden, Yvonne Zubria, Anna Algra, Stefan Senfeld, and Salvatore Rudiloso. Thank you very much for putting in all the hard work behind the scenes to prepare the press content for this conference. So tomorrow, we'll be looking forward to some interesting studies. I don't know if you've already looked at the program. There'll be a number of large observational studies on various risk factors, genetics, and associations with stroke. So I hope you enjoyed this session and have a nice evening.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.